from CST team, from NACO, from ITEC, and all others who have contributed to the session. So I acknowledge their contribution to this session, and it's not my session, it is session for everyone from everyone. What I am going to do today basically is, first thing, I got a lot of feedback that I was speaking a little fast and need to be a little slow for people to understand. So I will try to be slow and try to be, I'll just give you a very quick update on guidelines once again, focusing on pediatric ART guidelines, particularly ART for children with TB, because there were a lot of questions on this issue. Answers queries from field from 8 July session, remaining FAQs which were not covered, programmatic issues, and then we'll have some frank talk and introspection also. Again, I'm not going to revisit the ART guideline for adult, but I have put up this slide for you to think later on what are the conditions where we start irrespective of CD4. That's all. Again, last time I showed you that why we moved to 350, why to 500, and why we are thinking of moving to above 500. What are the studies? So you have to just recollect those studies. Why we moved to 350 was CIPRA-HTO1 study. Moving to 500, evidence came from randomized control trial SMART and HPN 1052, and above 500 is coming from Temporuno trial and the START trial. HIV 2 guidelines, again I will just quickly recapitulate that ICTCs should have 2 differentiating kits from 2 different companies, preferably with 2 different immunological principles. This is supplied by NACO, and you have to check when you are talking about HIV 2 diagnosis. Samples which are found as HIV 2 reactive by 2 differentiating kits, these are to be reported as HIV reactive and no further confirmation is required. And the patients are sent to ART center for initiation on a protease inhibitor based therapy, that is tenofovir, lamivudine, lopinavir boosted with ritonavir. If the sample is found as HIV 2 reactive by 1 differentiating kit, then again the algorithm of sample found positive for HIV 1 and 2 reactive has to be followed, and that algorithm is that if a sample is found to be HIV 1 and 2 reactive, the ICTC should refer the patient to ART center. ART center will give a referral form and guide the patient to go to which referral lab. There are 13 referral labs designated for this purpose of HIV 2 diagnosis. Patient himself will visit the lab and give the samples there. This is slightly different from the office memorandum because we are still establishing a mechanism for sample transport. So presently patient will have to travel, and once that mechanism is established whereby the sample will be transported from ART to these referral labs, then patient will not have to travel. But as of now, patient will have to travel to referral lab from ART center. Referral lab will do a confirmatory test and share the result. HIV 2, all patients on HIV 2 or 1 and 2 reactive will be treated with a PI based regimen, as I said earlier, tenofovir, lamivudine, lopinavir boosted with ritonavir. I will quickly recapitulate the guideline for children because there are a lot of questions that came in from the field in the last guideline. Again, the guidelines for children less than 5 years treat all children regardless of CD4 count or percentage. Whatever be CD4 count or CD4 percentage, all children less than 5 years must be started on ART. I think that should be very clear carry-home message. For more than 5, it is just same as for adults. Again, just 2 guidelines what to start. Zidovudine, because tenofovir cannot be used in children presently because of non-availability of suitable formulations. It is a zidovudine which is preferred NRTI for initiation in children unless they are anemic when you use abacavir. For all children less than 3 years, it is lopinavir, ritonavir which is the preferred regimen. For children more than 3 years, it is basically Efavirenz. So very clearly, zidovudine or abacavir depending on hemoglobin, lopinavir, ritonavir less than 3 years and more than 3 years, Efavirenz. So that clarity should be there. Again, this is just to write that same in the format. Up to 3 years, zidovudine, lamivudine, lopinavir, ritonavir. For non-anemic, for anemic, abacavir, lamivudine, lopinavir, ritonavir. Above 3 years, Efavirenz replaces lopinavir, ritonavir. Okay, but there were a lot of questions on children with TB. I will spend little time on this. There can be 3 scenarios: children more than 3 years, more than 10 kg, less than 3 years, less than 10 kg, which are where the guidelines are clear. But children more than 3 years and less than 10 kg, a very unlikely scenario unless the child is malnourished, is not picking up weight because of HIV. This scenario can be there. But if a child is more than 3 years of age, more than 10 kgs and is on nevirapine, then you have to change nevirapine to Efavirenz. If child is less than 3 years, less than 10 kg, clearly Efavirenz cannot be used. The child has either to get a lopinavir ritonavir boosted with additional ritonavir, which might be difficult because ritonavir separately may not be available in syrup form. Again, in such, other than super boosting, the option is basically continue with nevirapine but adjust the dose to the maximum. That will be 30% more than regular dose, and it is according to the body surface area for which guidelines have been given. Now the questions were asked of children who are more than 3 years but age is less than 10 kg. For children older than 3 years, it will be Efavirenz, even if weight is less than 10 kg. Even if weight is less than 10 kg. But if age is less than 3 years, then it will be lopinavir ritonavir. I hope this is clear. If you still have queries, you can go through this slide later on. I am getting questions in between. Again, we will be compiling these questions and send you a reply by email. Now, how to adjust the dose of Efavirenz if child is more than 3 years and more than 10 kg. This is a situation where we will be using Efavirenz. So, the dose is according to the weight, 10 to 15 kg, 15 different weight bands. The dosage has been clearly given. This was shown in the last NDLS also, and guidance has also been sent. Special situation, children less than 12 years where tenofovir cannot be used, abacavir toxicity, what we should do? Basically, if there is abacavir hypersensitivity, we should use AZT. But if we can't use AZT because hemoglobin is low, then basically we should use D40. But again, this D40 should be changed with AZT as hemoglobin improves. In near future, we will have the smaller formulation, suitable formulation of tenofovir for children. Then this can be used in all cases. Again, issue of ART and TB treatment in children on lopinavir ritonavir. It is very clear that in lopinavir ritonavir, in adults we are using rifabutin, but in children we cannot use rifabutin. Preparations are not available, safety data is not available. So it will be either super boosting with additional dose of ritonavir, or in case there are toxicities, ritonavir is not available separately, then it will be basically nevirapine again in the dose as per body surface area in a higher dose. Second line ART, there were questions on this second line ART. Presently there is no second line ART for children other than abacavir 3TC lopinavir ritonavir, but if abacavir has been used in first line, AZT will be used. But if there is anemia, then option is to continue on the same regimen. I think I am not going too fast this time. Again, we can use a triple NRTI regimen which is not as efficacious as 2 NRTI plus PI or 2 NRTI plus 1 NRTI regimen. But in situations where you have no other option, we can use AZT or D40 with 3TC with abacavir. Again, single formulations of these pediatric formulations are not available, and this will have to be made available at centers of excellence only. Recently there was some shortage of ZL pediatric and guidance was sent. I am just reiterating this guidance. This guidance is applicable only till the time you have problem with the ZL pediatric for which supplies orders have been placed. But for older children 14 to 20 kg in weight, that is 19.9, half tablet of adult can be used. 20 to 25, 1 tablet of ZL pediatric in the morning, 1 tablet of ZL adult in the evening. And more than 25 kg, you can use the same dose of adult ZL, that is 1 tablet morning evening. And these have been calculated keeping the weight band in mind and the dosage that were given in the pediatric formulations. There are some changes in early infant diagnosis. The guidelines are basically earlier guidelines in 2011. If you go into the document, they say if at 18 months your antibody test is negative, stop ART. That is the algorithm. The change is which has been already been communicated. Do not stop ART even if antibody test at 18 months is negative. In fact, WHO does not recommend a 18-month antibody test They say if you have got 2 DNA PCR positive and ART has been started, it has to be continued lifelong. But now we are validating whether this is correct or not, and we have got data from children who tested antibody negative at 18 months and we are evaluating that. But the guidance is these children should be continued on ART and further followed up with a DNA based PCR on DBS without discontinuation of ART. Again, final decision on continuation will be taken by pediatric TRG, which is meeting on 19th of August, but as of now this has to be continued. Again, there were 2 algorithms in EID, A and B, for less than 6 months, more than 6 months. Now there is unified single algorithm for new EID guidelines, which has already been circulated to all sites. Again, earlier practice was we used to carry out a DBS sample for DNA PCR taken from ICTC, sent to the DNA PCR testing labs, and if it was found to be reactive, child was sent to ART center to do a whole blood testing sample, which was sent again for DNA PCR, and once it was confirmed, then the child was started on ART. Now this WBS second has been replaced with dried blood spot. So you can do 2 sequential DNA PCR tests using dried blood spot, meaning thereby first dried blood spot, if it is positive or it's called reactive, then you have to collect another sample and send it to the lab, and if that is also reactive, then start ART. Again, in the NASEP, that is National AIDS Clinical Expert Panel, we have been getting lot of queries. I clarified some of these in the last session also, but these are the commonest queries, 5 common queries that we get from different centers. Though I can be very clear that, very frank, that we are not getting queries from most of the SASEPs. It's only selected 3 SASEP I don't want to name who are sending us the queries. Maybe you have got the expertise, but I think there will be situations where SASEP also require expert opinion. Management of multi-NRTI exposed clients presenting with failure. Management of patient failing on TDF based regimen. Patient referred from private sector. Cases with lamivudine toxicity suspected, and CD4 viral load discordant cases. I will quickly try to give some guidance on this based on the TRG, last TRG recommendations. Multi-NRTI exposed patient, the substitution guidelines are if they have got tenofovir toxicity, then these patients need to be substituted with zidovudine if they are not anemic, or with abacavir if they are anemic. If there is abacavir hypersensitivity, in those rare situations where they are anemic, abacavir hypersensitivity is there, we can use stavudine if there is no history of stavudine induced toxicity, but shift them to AZT within next 2 or 3 months after building up their hemoglobin, which can be built up because of ART also, and which can be built up if there are other reasons for them to be anemic. But if these patients who are exposed to multiple NRTIs are failing, meaning thereby they require to be switched to another regimen, if there is no TDF toxicity, there is no anemia, basically they can be shifted to AZT3TC boosted PI. But if there is TDF toxicity and anemia is present where you can't use zidovudine, the new regimen will be a stavudine based regimen with boosted PI, again shifting back to AZT as soon as anemia is corrected, provided there was no AZT induced anemia. We are emphasizing that if there is a history of AZT induced anemia, we cannot re-challenge the patient with AZT under any situation. Again, tenofovir toxicity, this formula was given in the last NDLS and it has been circulated also, and based on this the dosage modification for tenofovir and lamivudine is also given. There is no dosage adjustment required for efavirenz in case of renal toxicity. These guidelines have been sent, and since you will require different dosage of tenofovir, lamivudine, you will require separate tablet for which patient have to be sent to centers of excellence who will procure these drugs as of now. So this was little background about the guidelines. Now I will quickly going through the questions which were asked during the NDLS part 1. First question was from JJ Hospital. 2-year-old child, hemoglobin 9.5, no opportunistic infection, what should be our ART regimen? I think it is very clear from the children regimen, pediatric regimen that I have shown that It is a zidovudine, which is a preferred NRTI. Hemoglobin is 9.5. It is just on the margin. So you have to monitor hemoglobin after 2 weeks, 1, 2, or 3 and 6 months. This for all patient, adult and children who are initiated on zidovudine. But from our ART assessment, we have noticed that only 10% of centers are following these guidelines of regular hemoglobin monitoring after initiation on zidovudine. So that is a caution we have to see. If you initiate, you have to monitor hemoglobin. If child is anemic, then we can use Efavirenz, hemoglobin equal to or less than 9, and lopinavir ritonavir is recommended because this child is less than 3 years. All children less than 5 years are to be initiated on ART irrespective of CD4 count, just to re-emphasize. Another question which came from Lucknow and Safai was, again child more than 3 but weight less than 10 kg. I think I have given this in the guideline just now, that if children are older than 3 years, even if weight is less than 10 kg, Efavirenz is the component to be used, but if they are less than 3 years, it is lopinavir ritonavir. Again, the next question was 12-year-old child, weight 38 kg, regimen preferred is AZT or TDF. Answer is clear. If tenofovir regimen can be used in children which are more than 35 kg and above 12 years of age. Child is just 12 years, we can use a tenofovir based regimen, though tenofovir is approved for children older than 2 years, but formulations available now are only adult formulations, so children more than 12 years can be started on a tenofovir based regimen. Another question was, what is second line for children with PPTCT exposure? Again, it is a protease inhibitor whenever you have got a exposure to nevirapine in the past. But if they fail on this PI based regimen, since protease inhibitors, especially lopinavir, have got a high genetic barrier for resistance, then we have to continue such patient on second line even if they fail on the current regimen. But we are again discussing this further to decide programmatic approach. In case children started on lopinavir ritonavir in the first line, they fail, they can still go to nevirapine Efavirenz in the second line in the event of their failure on the first line. Child started on ART at age of 15 years, he crosses 15 after starting at 12, he is on adult regimen. In the monthly report or in the register, they should be shifted from child section to adult? No, presently not. Presently they are counted in the children's section less than 15 year also, because there is no way you can update this age. Whatever age at entry was given, that is taken as. But the new PLHIV software which is being modified will take care of this issue, as this will link the age to date of birth. If date is not available, month of birth or year of birth of PLHIV, and will auto update these children into adult category. Another question was, child below 3 years on lopinavir ritonavir crosses 3 year, should be substituted with Efavirenz? No. This is initiation guideline that less than 3 years on lopinavir ritonavir, more than 3 years to be initiated on Efavirenz. But once initiated on lopinavir, has to continue on lopinavir. This is like any other regimen. You continue on first line regimen or whatever regimen has been initiated, that is the first line regimen. By definition, second line regimen is the regimen when the patient is substituted with another regimen in case he fails on the first regimen. So in these children, the lopinavir ritonavir based is his first regimen, he will continue on the same, and NRTI will be reserved as second line option for such children. Another question was, 10-year-old child, CD490, 2005, received single dose, should he start ZLE or what else, and what resistance testing should be done? Answer is again, prior exposure to NRTI, that is nevirapine is there, even it was single dose. For the simplicity, guideline has been taken that these patients should be started on PI based regimen. There are certain research studies available, and WHO guidelines also say that where the nevirapine exposure was less than 6 months or more than that, we can consider nevirapine, but for simplicity of guideline in the field, TRG decision of NACO was any exposure to nevirapine irrespective of duration, when it was exposures were there, basically children should be started on PI based regimen. Baseline resistance testing is currently not a part of national program because of low levels of resistance, and WHO is supporting NACO on doing a drug resistance surveillance to see what is the baseline resistance, which will form further guidance for doing a baseline resistance or not. Another question was, a child's 24 kg started on full dose of TDF from private. What should we go? Basically, we have to follow the standard guideline. We don't have pediatric formulations of TDF. So basically, we have to follow what are the initiation guidelines for children of this age and weight are there. 10-year-old child, CD490. Oh, I think this is a repeat question. Okay. Now, a different set of questions were asked. Grade 1 rash, grade 2 rash, in spite of antihistaminic, temporary discontinuation of ART, patient is not improving. So, what should be the guideline in this? The guideline for rash evaluation were sent to all ART center, and I would just like to reiterate them. If rash is not severe, do not discontinue ART. In some cases, if it is recurrent, offending agent has been identified and it's not responding, substitution may be required to improve adherence, because adherence may go down if patient get recurrent rash and is not able to continue his therapy. But if rash is self-limiting, does not require substitution. We have also to keep in mind other causes of rash, which could be CPT, could be other concomitant drugs the patient is taking. But again, we have to be very careful in the grading, and we have to see if there is any mucosal involvement of oral mucosa, eyes, or worsening of the rash. This may immediately warrant substitution or discontinuation. 10 is basically toxic epidermal necrolysis, which is a grade 4 rash. We have to remember nevirapine is the most commonly drug used for rash, but now we are not using nevirapine either in adults or in children for initiation, so the incidence of rash will go down. But cotrimoxazole can also cause rash. Efavirenz can also cause rash. Many ART centers have identified lamivudine rash, which is not very common, rather I will say it is very uncommon, but it has been identified in some cases by exclusion criteria. Sporadically, zidovudine, lopinavir, atazanavir, in fact any drug can lead to a rash. This has to be kept in mind as a physician. So we have to be very clear in suspecting other offending agent, and I will just give you what are the algorithms and grading of rash. A grade 1 rash is erythema or pruritus. Grade 2 is diffuse maculopapular rash, could be dry desquamation of the skin. Vesiculation or moist desquamation, any ulceration form grade 3. All other forms are mucosal membrane involvement, Stevens-Johnson syndrome, 10, exfoliative dermatitis are grade 4 rash. So you have to really grade the rash and do a photo documentation. In case you are sending a referral to SASEP for e-approval, basically then you require a photo documentation of the rash, for which digital cameras have been provided to all ART centers. So management of rash, as I said earlier, grade 1 and grade 2, avoid changing ART as far as possible unless it is recurrent, disabling, offer symptomatic treatment, antihistaminic, lactocalamine and other things. But if it is moderate, it is necessary to discontinue the ART or suspected drug till the condition resolves, and subsequently we can cautiously substitute the offending drug with another drug from the same class. But if it is a grade 4 rash, we don't do any such substitution and use a different class of drugs. In grade 4, patient has to be hospitalized. All drugs have to be discontinued. Offending agent should never be rechallenged, because grade 4 rash, 10 and Stevens-Johnson can be fatal also. These require active acute management, including use of steroids and change of ART to new guidelines. This is the algorithm. I will not go into details. This is the same algorithm which I have just told you, but this algorithm is slightly different in the sense this is for patient who were started on an NRTI based regimen and started ART 2 weeks after CPT initiation, meaning thereby CPT has been ruled out as an offending agent, and offending agent is basically either NRTI or NNRTI. So in this sequence we replace NNRTI first and see whether the rash is involved or not, and in case rash is not subsiding, then we actually substitute the NRTIs. So basically this algorithm will require to be followed in cases which are having NNRTI rash, and this algorithm is used for detecting basically even the lamivudine toxicity. Okay, there are some questions whether tenofovir, emtricitabine, efavirenz can be substituted. Yes, as I said earlier, emtricitabine, lamivudine are equal in efficacy. There is a systematic review of data from 5 studies which say that you can use these interchangeably, and your FTC, that is emtricitabine, is 3 to 5 times costlier than? No, this patient does not need to be referred. This is the same regimen. Safdarjung Hospital, I saw your question. This is the same regimen, so there is no need for referral to CSEP. We are trying to reduce CSEP referrals only to second line and to complicated cases. For substitution with a PI based regimen, only E approval will be required. So we are trying to reduce the patient traveling from one facility to another facility. Okay, the next question was, can the substitution of nevirapine with efavirenz can be done at the ART center itself? Basically, first thing is that reason for substitution needs to be clear. The grading of the rash has to be done. If it is grade 3 or grade 4 rash, you cannot substitute nevirapine with efavirenz. But it can be done at the ART center itself. In case you require to substitute them with a PI based regimen, E approval from CSEP is required with a photo documentation only. Efavirenz 600 mg holds good for Indian patient. This question has been coming up, and this question was in fact discussed in depth when Dr. Rajashekharan was superintendent at hospital, Tamram Hospital, and basically it was thought that we can use lower dose or a higher dose also. 800 mg initially it was suggested. So this is the regimen 600 mg dosage to be used for any person weighing more than 40 kgs. However, data regarding 400 mg versus 600 mg is being looked into by WHO, and there are evidences that in future WHO may recommend for 400 mg of efavirenz, basically depending on the meta-analysis of the data that is coming in, but still the guideline is to use 600 and not any dose lower than that if your weight is in that weight band of 40 kgs. If patient is on ZLN after starting AKT, which regimen? Definitely nevirapine needs to be changed to a efavirenz based regimen because of the drug-drug interaction between rifampicin and nevirapine, and this ZLN need to be continued even after completion of TB, and efavirenz should not be substituted with nevirapine, which was the earlier guideline. There is a question, in which condition abacavir can be used. I am coming to that. SKM CH, I am coming to that. Okay, can we start CPT in pregnant patient? Yes, you can start. Indications are same in any trimester. Breastfeeding is also not a contraindication. Another question, very important question, was if a patient is on antiepileptic drugs, can we give efavirenz? It has been reported that there is significant interaction between phenytoin and efavirenz to the extent that the efavirenz may become undetectable level, or level may become very low, and this may lead to poor control of viral load, patient's viral load. So it is advisable not to use efavirenz in patient with known epilepsy on treatment. But suppose there is a compulsion to use efavirenz, we cannot use another drug, then phenytoin and carbamazepine, phenobarbital should not be used, and anticonvulsants like valproate, clobazam, lamotrigine can be used in consultation with a neurologist, whether these will be suitable for patient's condition or not. Again, question on serodiscordant couple, whether we should start ART in serodiscordant couple. I hope it is very clear. Serodiscordant couple is, and then one of the partners is positive and other person is negative. It could be husband or could be wife. WHO is very clearly recommended to starting ART initiation in serodiscordant couple based on HPTN 052 study, which I elaborated in the last NDLS, that if you start ART in the positive partner, it prevents transmission of HIV to the negative partner by as high as 96%. But this is still to be implemented by NACO, and OM will be issued shortly, because this requires a lot of issues like counseling, regular 6-monthly testing of the negative person, adherence to drug, because the positive person may be having high CD4 count and may not adhere to therapy, leading to drug resistance. So these guidelines are yet to be sent. PrEP is still not recommended in NACO guidelines at present. Should we check LA before starting abacavir? Abacavir adult is not available in ART center. This question came earlier also. Abacavir lamivudine has now been sent to SACS. SACS have been given guidance to send it to ART center 2 weeks ago. Ideally, HLA antigen should be done, but in India we have observed very few patients have got abacavir hypersensitivity, and this testing is also not freely available in the program. It is selectively available, is very costly, costing up to 5 to 7,000. So it is not necessary to test HLA, but patient should be explained about possible hypersensitivity and should be closely monitored in initial phase, and very clearly you have to understand, if there is a abacavir hypersensitivity, person should not be rechallenged, it can be fatal. So counseling of the patient, that is why we always lay a lot of emphasis basically on the counseling of the patient, ART preparedness, that at least 2 to 3 sessions of patient's counseling should be done. Though abacavir is not the first line in adults, unless there is a issue that you cannot use tenofovir. In children, anemic children, this is the drug of choice. So you have to be very clear when you counsel the parents or the attendants of the children. This guidance has been sent that abacavir 600 plus 3TC 300, which is available in plenty at many centers and most of the SACs. Adult patient on first line with toxicity, non-tolerance, contraindication to both zidovudine and tenofovir. Not only either zidovudine or tenofovir, if there is a toxicity, non-tolerance or contraindication to both of them, then it can be used. Adult patient on second line with toxicity, non-tolerance, contraindication to tenofovir, where zidovudine default have already failed. So you cannot put AZT back on this patient if there is a toxicity to TDF. Children who are on abacavir pediatric formulation and weight more than 30 kg, they may be counted in less than 15 group in MND, but if their weight is more than 30 kg, they can be shifted to adult tablet of abacavir 600 plus 300 FDC. Dose will be half twice a day or one tablet once a day of 600 mg and 300 mg. Any other patient which is advised by SESF can also use abacavir. Third line ART, it is very clearly last time also told that third line ART is under procurement. The tenders have been opened, and as soon as the supplies are received, this will be started, but then this will be approval only by SESF at COE. Not all 54 SESF will be able to evaluate this patient. Only Center of Excellence will evaluate this patient after referral from ART plus centers, and final E-approval will be given by NESEP. The question was about partial dispensation of drug only if veltagravir is not available, other drugs, no. NACO is very clear that partial dispensation of any drug should not be given. If creatinine is normal, do we still need to calculate creatinine clearance? And what is the minimum creatinine clearance? No, creatinine clearance is not required to be calculated. In every case, it is only to be calculated when serum creatinine is more than or equal to 1.5. Formula I have just given you, CG formula, and now there is a app available, and ITAC has shared this app that center can put in any smartphone. In your app search creatinine, GFR calculator and Abbott, then you will get basically the creatinine clearance. Again, how to adjust the dose, I think this has been very clearly given already and reiterated today. Can stavudine still be used in multi-NRTI exposed? I have already given this. Yes, this can be used in certain situation in substitution where there is a TDF toxicity, patient is not failing, patient cannot be shifted to AZT because of anemia, abacavir hypersensitivity is there. In that situation, which may be less than 2% or 1% of the patient, T40 can still be used for initiation, but again this has to be substituted with AZT as soon as anemia is corrected. I hope I am clear till now. Most of your queries have been answered, but some of the queries are coming still, but please send hard copies of this lecture. We will be sending you a link where you can download this link and listen to it again slowly, repeatedly if you have any clarification. And if you still have any clarification, you can ask by email from any of the COEs, from me or anyone. Okay, the next question was from Sion, PCOE. They have got a pediatric SESF. They are doing it through telemedicine. No, we don't approve of this because SESF has to be done in presence of patient and caregivers, and I am very clearly conveying this message to the SACs and other people and Sion that SESF has to be done in presence of the patient and not telemedicine, not even through video conferencing. Mentoring is okay, but not CESEP. Okay, now there was a question about PEP and PEP regimen if source is on second line. PEP drugs have to be made available through ART centers. In case of hospitals which do not have ART centers, this will be supported by NRHM, for which a circular was sent long back. PEP should be offered to all children where it is required. If they are sexually abused, it will be a lopinavir-ritonavir based therapy if efavirenz cannot be used if children are smaller. Now, if the source is on second line ART, PEP regimen will be darunavir-ritonavir, raltegravir. Failing on second line. If it is failing on first line, it will be a different NRTI backbone. Again, I will clarify, if the person is failing on first line, use a different NRTI backbone based for PEP. If the patient is failing on second line, because some of the patients failing on second line may be admitted to the ward and there could be needle stick injuries, then they should be started on darunavir-ritonavir, raltegravir, which can be procured by the center using the contingency grant. This question was that TLE pill is quite large. Yes, it is quite large because it contains 600 milligram of efavirenz, 300 milligram of tenofovir, 300 milligram of lamivudine. Now, some companies are trying to make a smaller pill, but if any person finds it difficult, it can be broken into two, but should be consumed one after another, not half BD or after an hour. It should be consumed one after another. Okay, the question was, adult female not on ART with CD4 456 came up with abdominal pain. USG shows hemoperitoneum, left ectopic kidney, abdominal shows multiple dilated loop, basically suggesting extrapulmonary tuberculosis. Basic question, it is not easy to answer in 1 minute of a question, but I am sure Kopal must have asked their center of excellence what to do in this and must have taken care of the patient. Basically, diagnosis of abdominal tuberculosis sometimes is more clinical with supporting evidence, and laboratory confirmation, particularly biopsy, may be difficult because of limitation of resources. But centers having facilities like US guided FNAC can opt for aspiration of the lymph node, hypoechoic lesion in the liver or the spleen, do AFB staining, fungal stain, cultures, and then also if there is exudative ascites, the ascites is there, then we can do ascitic tap and basically see ADA levels or serum albumin gradient, which can be taken as diagnosis of TB peritonitis. Pregnant woman takes TLE single pill and feel drowsiness. Drowsiness is one of the sides of efavirenz which many patients experience in the initial phase. So it is very important to have reassurance and tell that side effects will settle within few days, within 2 to 3 weeks. Most of the patients, these side effects settle down. In fact, now we have a large experience of these now patients on efavirenz, almost 200,000, 2 lakh patients, and very few patients have to stop efavirenz. But we have to look for other causes of drowsiness, could be a severe anemia, could be some other causes. But if the woman is severely symptomatic, cannot tolerate it, then we may have to substitute with lopinavir-ritonavir. Bitter taste of lopinavir-ritonavir. Yes, it is very bitter, it has got a lot of side effects, it is unpalatable, children find it very difficult to take, but we have no other option than to reassure child, caregiver. We can add some sweetening agent, can add sugar basically, but just for information, sprinklers, the powder of lopinavir-ritonavir are now under development by one Indian pharma company which is trying to take care of this issue of the taste. Osmania, lipodystrophy are still increasing in after stopping stavudine. Those patients who have developed lipodystrophy, they do not disappear after stopping. They stop after discontinuation of stavudine but do not disappear. But you have to remember other NRTIs like even zidovudine or even efavirenz can lead to lipodystrophy. I don't know how many of you are monitoring lipid profile and have the facility to monitor lipid profile when you are using efavirenz. If you have facilities, you must do a lipid profile at least once in a year for patients started on efavirenz based regimen. But facilities may not be available at many centers. Patient CD4 less than, how many days we are expected to start ART? A good question. If there is no OI, ART should be started as soon as possible after preparedness counseling is done. This should be very clear. Preparedness counseling takes lot of care of lot of issues, particularly adherence later in the stage. But if your CD4 count is less than 50, it is unlikely. We have to really look into patient having some opportunistic infection and treat them. But in our practice, we have seen patient with CD4 count of 2, 5, 10 without any OI. In such cases, it should be expedited, and these 2-3 counseling should be done within a short period. But if patient has got TB, then again you should start ATT and try to start ART within 2 weeks after stabilizing ATT. How about pregnant patient? Do they require preparedness counseling? No, they do require preparedness counseling, but ART should not be withheld for preparedness counseling. Their preparedness counseling has to be quick, on the same visit, initiation on the same visit, and a continued preparedness counseling while on ART and adherence counseling. EID discordant child on ART, 3 rapid tests at 18 months turned out to be positive, but DBS were negative. Again, I said that ART is to be continued in all cases where 18 months antibody is positive or 18 months antibody is negative. They have to be further evaluated, on which a protocol has been made, but ART has to be continued, and such cases should be sent to NSF for further opinion. There are some patient who's, now I have seem to have answered all the queries from the field. Now I will take up the questions which were remaining. I have 15 minutes. I have 2 choices: to be fast and answer these questions, or continue beyond 1 hour, or take up another session. I think I would prefer the middle option, that we can continue for 5 to 10 minutes beyond 3 o'clock also. So there are some patient who repeated plasma viral load done thrice but not detected. HIV-2 has been ruled out. They are on first line ART, no OIs. What should be done? How frequently we should do the viral load? Basically, we have to see what are the other causes of CD4 count not increasing, though the viral load is basically not detectable. One you have already done is ruled out HIV-2, which is the commonest. But we have also to rule out now HBV infection, SCV co-infection. You have to see if patient is on AZT. Is there leukopenia? Is this CD4 decline or low CD4 due to leukopenia? If leukopenia is there, substitute with AZT and then follow up with total leukocyte count and CD4 count. Check for concomitant diabetes. Check for other causes of low CD4 count, systemic corticosteroids, immunosuppressant. Again, look for some opportunistic infection, but whatever you do, continue CPT, don't stop CPT. Again, this could be another entity called virological and immunological discordance, and it has been seen that the patient with immunological virological discordance are at higher risk of fatal and non-fatal non-AIDS event. And because this risk is mostly because of a low current CD4 count. Ideally, viral load should be done 6 monthly, but one should be satisfied even if you are able to do it yearly with close clinical supervision in case the viral load testing is not available. Coming to pediatric queries, less than 12 year abacavir toxicity, answered already that if there is abacavir hypersensitivity, we should use AZT. If AZT is not possible, use AZT. If anemia is there, use D40, but again go back to. I am reiterating pediatric queries in 2 forms. One was questions from the field and some FAQs which we have already prepared. The issue was basically to re-emphasize on the issues related to pediatrics. Now this query is at the age of 15 year, patient's weight is 36 kg. Do we shift him to adult dose? Yes, if they have got weight of 36 kgs, we can shift them to adult abacavir 3TC, which is now available in plenty, and this will reduce the pill burden. Those who are immunological failure in first line, later put on PI based regimen in private as second line, then currently on darunavir eltagravir. This is from some of the centers. There is no provision for third line in the program. As of now, it is being procured, and as soon as this is available, the guidance will be sent. Till that time, they have to continue their own regimen, whatever regimen they are continuing. Again, in case of patient with lamivudine toxicity, we give plain zidovudine, plain TDF, plain means separate zidovudine, separate TDF along with an NRTI or PI. But if such patient develops zidovudine induced anemia, what do we develop? Stavudine can still be used for such patients. Only issue will be availability of stavudine as a separate drug. Abacavir is an alternative which is available as a separate drug, but again abacavir will have to be procured separately, and for that again patient has to go to COE. Another question was some of the AIDS defining illness like PCP, CMV, retinitis, cryptococcal meningitis, after how many days of initiation of treatment for opportunistic infection we can start ART. ART initiation should be delayed for 2 to 6 weeks depending on what drug is used for cryptococcal meningitis. It is very clear guideline that you should treat cryptococcal meningitis first, wait for 2 to 6 weeks till the treatment is completed. If you are using amphotericin B, if you are using fluconazole, for some reason longer induction phase will be required and you cannot use ART till that time. For PCP, treatment may take 2 to 3 weeks for initiation, and CMV retinitis also may take longer time, and once you have treated the conditions, the person can be started on ART. For such patient, at least 1 month's time may be required, but it will depend on how the person is responding to treatment of OIs. But once, till the time ART is started, care must be taken to avoid any additional infections at the hospital. If the person is hospitalized, he is not on ART, is immune suppressed, severely immune suppressed, and ART is not there, so we have to avoid cross hospital infection, particularly tuberculosis. Child more than 3 years, weight less than 3 years, can we start on efavirenz based regimen? Yes. As I said, it cannot be used in less than 3 years, weight less than 10, but it can be used if it is more than 3 years, weight less than 10 kgs. Can efavirenz be given as 400 mg if patient is having too much giddiness, and when patient settle down, increase it to TLE single dose? Again, 13-year-old, 36 kg, history of hypersensitivity, is at T3DC efavirenz. Should the dose of efavirenz be same or reduced? There is no role of low dose of ART medication. We keep on saying we do not have evidence from Indian patients about the dosage of antiretroviral drugs to be used in our condition, and we are using the Western data, but it is for us to develop own data. But till the time data is not there, there is no role of low dose of ART medication. You have to use the standard approved dosage of antiretroviral drug. Subtherapeutic dose may lead to drug resistance over a long period of time. However, efavirenz, as I told you earlier, studies with 400 mg efavirenz have been done, and a meta-analysis is on the way whether we can use 400 mg instead of 600 mg, which is likely to reduce the pill size of TLE also. And just to inform you, instead of tenofovir desoxycyprine fumarate, that is TDF, now we are having tenofovir alanine fumarate also, that is TAF, which is coming in, and its dose will be as low as 30 mg. So basically, in future we may have a combination of TAF with lamivudine with efavirenz 400 mg, but that is a scenario which is not as of now approved and is under evaluation by WHO, but its implementation may take up to 2 years. This information is more for your knowledge. Presently we have to use the standard dose of efavirenz. Children initiated on lopinavir, ritonavir, what is the second line option? Is it nevirapine efavirenz? But if less than 10 kg, we cannot use efavirenz. This is more of a hypothetical situation. It is less likely that child will not gain weight above 10 kg after initiation of therapy. Children gain weight quickly after initiation of ART and proper nutritional supplementation. Again, children less than 5 years, ART initiated irrespective of CD4 count. What is the criteria to detect immunological failure? Previously less than, it was based on CD4 percentage, but when they grow older, what is the criteria to detect failure? Even if the criteria for initiation has changed, let us be very clear, criteria for labeling them as failure remains the same. In children, if CD4 count is less than 15% in age group of 12 to 35 months, less than 10% in 36 to 59, and less than 100 for more than 5 years at two different 6 months apart, should be considered for switching a regimen. Pregnancy, I think I have given this early infant diagnosis, what are the changes in the guidelines. Again to reiterate, do not stop ART if your 18 months antibody test is negative. Do not, WBS is not required, 2 DBS, separate settings, one after another. Confirm 2 DNA reactive DNA PCR ART can be initiated. Single EID algorithm has to be followed now. Woman has delivered a child few months back. CD4 is over 500. She is breastfeeding, found HIV positive. Should be started? Yes. Because guidelines say it is not only for pregnant women. We always say pregnant women, but it's for pregnant and breastfeeding women. Again, if the woman is exposed to nevirapine and started on lopinavir-ritonavir prophylaxis in stock, is she eligible for ART? She has been exposed to nevirapine, she has been exposed to lopinavir-ritonavir prophylaxis when option B was there. Is she eligible for ART now? What to start? Yes, we will again start lopinavir-ritonavir because she was exposed to lopinavir-ritonavir and it was stopped after the breastfeeding was over as per option B. But lopinavir has got a high, so in this scenario lopinavir-ritonavir based ART need to be started again once she has become eligible for ART or gets pregnant again. We are doing DNA PCR by DBS and then by WBS. This was because earlier DNA PCR with DBS was not approved for clinical diagnosis. This was more for research use only. Now it has been approved. So now we have changed the algorithm and we will be doing 2 DNA DBS and 2 we are doing for the issue of sensitivity and specificity. What are the follow-up criteria for babies started on ART but found negative? I think this has been elaborated very clearly that continue ART at antibody test result, whatever, negative or positive, you have to continue ART. You have to basically repeat. If you just look at the lower portion and negative at 10 months, repeat 3 antibody tests at the same testing site after 1 month. If you have done 3 antibody tests, do 3 again after 1 month. There is the positive, continue ART. If they are negative, continue ART, do DNA PCR. DNA PCR negative, still continue but refer to NSF. There is no zidovudine syrup. I think zidovudine syrup authority has been given to SACS to procure this from their own level, at the center level, at the patient level. Wherever it is available, it should be procured, but unfortunately it is not available at any level. So in this situation where it is HIV2 or it is a nevirapine exposed, AZT syrup guideline cannot be implemented for non-availability of syrup. We should use lopinavir-ritonavir syrup in such situation. Though there is no strong evidence regarding safety and efficacy of lopinavir based infant prophylaxis. But since we have no other option, it should be used, and the dosage is basically for children of 3 to 6 kg, 1 ml twice daily, and children less than 3 kg, it is basically according to the body surface area. We are nearing our time, but I think we have clarified already on the PEP regimen. If source is failing on AZT, use TDF based regimen. If the source patient is failing on second line, use the third line drugs. Lastly, coming to co-infections, one of the co-infection in some of the eastern part of the country is in around 56 districts. HIV, the Kala Azar is still endemic. Kala Azar elimination has been taken up on the priority by the government on 1st of July last year, and all these patients with Kala Azar are basically being provided with MB-SOM, that is liposomal amphotericin B, free of cost under the National Vector-Borne Disease Control Program. But the problem is, if they are HIV co-infected, the Kala Azar tends to reoccur because of the low immunity. So it has been decided that for Kala Azar treatment among HIV visceral leishmaniasis co-infected patient, liposomal antibody 40 mg per kg body weight will be used in different doses. That will be on 10 doses, day 1 to 5, 10, 17. This will be provided by the National Vector-Borne Disease Control Program. But it is important for ART centers to see that all those patients of HIV who have got unexplained fever, who have got leukopenia, who have got splenomegaly should be evaluated for a visceral leishmaniasis using a rapid antibody test. Visceral leishmaniasis treatment should be started first like ATT, and then ART should be initiated 7 to 10 days after the patient has been adequately counseled. Though the office memorandum for this is still to be issued from NACO side. Again, just to re-emphasize that ART initiation among patients with history of TB to be started irrespective of CD4, irrespective when they had CD4. It was 5 years back, 2 years back, 3 years back, before detection of HIV or after detection of HIV. ART has to be started irrespective of CD4 count. Usage guideline on usage of abacavir lamivudine access has already been given, adult regimen has already been given, and I have just reiterated the same. Cipilline syrup, if you don't have sufficient supply from SACS, I think the BSD division has now made tender for the availability of cipilline syrup, and this is being sent to all ART centers. SACS can also purchase this using AIT. When will the courier agency collect the PVL samples? This is under, again, a transport agency is being hired, expression of interest has been put up, but still the agency and the rates for this transportation are not finalized. Can we think of changing ZLE to TLE as there is acute shortage of Efavirenz? No, there is no such advisement. Don't change the regimen unless it is technically required and not for the logistic region. Efavirenz supplies are being expedited, orders have been placed, and if you don't have supplies, relocation will be done based on your request. I think I have been able to complete this session in time, and before we say goodbye, I have some thoughts for ART center medical officers. Some of the centers have already left. I can see from 421 now we have 391, so almost 30 centers have already left. Maybe some of you did not find the session interesting, or you found it too basic. You can, maybe you had some other commitment, you can just log it on the recorded link. But I would like to take this opportunity for ART center staff. It is not medical officer, it is a counselor, data manager, pharmacist, everyone, to have some introspection. What are you doing? I am just bringing out some basic things. In the next 2 slides, I would like your attention, full attention on those 2 slides. Basically, don't say thank you, I am still continuing. I am still continuing, I am getting lot of thanks, I am continuing. Basically, how well versed are with your monthly progress report? You don't have to answer to this me now or ever. You don't have to send reply to me on this on email or on your window now. You have to think when you go back, sit in your ART center, put this question in front of you and ask yourself, do you know from where you get the number of patients registered in HIV care? Which indicator it is? Which 2 point, 3 point, 5 point, which is this indicator? How do you calculate it first time? Do you know what is active HIV care? Which indicator is this? Because in my interaction with many review meetings, ART medical officers were not aware of what is 2.5, 3.5, 2.10, 3.10, which are 4 critical indicators. Dr. Manish had given you a very good session on M&D tools. Now you have to think back whether you remember it and you are doing it, these things or not. Do you know how many patients were started on ART at your center in last month? Which indicator is this? How do you get patient alive on ART? There is a column of missed patient. Do you detect these missed patient when you do calculation from ever started on ART to get alive on ART? Don't answer me. You have to really think whether you are looking at monthly progress report before it is sent. Every week or every month you get 30 to 50 to 100 to 5 patient in pre-ART care depending on the patient load in different centers. Does the medical officer or the senior medical officer ever look at pre-ART register to see the column 20 whether all these patients have undergone baseline CD4 count or not? Just think over, are you doing this or not? Have you ever looked at patient not initiated on ART other than preparing a list and giving it to CSC? Do you follow it regularly? Do you think it is your responsibility? Do you think it is your job only to see patient and prescribe drugs? When you have a simplified one first line regimen, one alternative regimen, simplified one second line regimen, no third line regimen, only CD4 count monitoring, no viral load monitoring unless you fail on CD4. Do you think it is your job to see only patient, prescribe drugs, or you have to look at the registers, reports, monthly progress report? Yes, it is your job as per your technical terms of reference. Are you looking at retention cascade 2.12? Most of the medical officers do not know what is 2.12 and what is 2.12A to E, but some guidance has been sent in the recent past on this, and I request you to look at the retention cascade carefully. That will tell you how many patients you are losing. I have another question. You may find it philosophical. Are you really concerned about quality of services provided at your center? Or are you just taking it as a 9 to 4 job or 9 to 3 job? And last question. This question is more for the ART medical officer and everyone. Do you really work as a team in ART center, or you work in silos that this is my job, this is my job, this is my job, or we really work together? Have you any practice of sitting together once in a week over a cup of tea to discuss what are the issues? On a afternoon when you have less load, just sit over a cup of tea, everyone, and see what gaps are there between different people, what communication gaps are there. We did medical officers training at 475 medical officers over 13 refresher trainings, but how many of you have passed on this information you received to other medical officer at your center, to the counselor, data manager, pharmacist of your center? Did you share the PowerPoints that you received in refresher training with other? The person who was trained in refresher training, did you have opportunity to have any session? Did you brief your nodal officer? Many sessions, many refresher training, only medical officers were present. Did you brief your nodal officer that basically these were the guidelines which have changed? Data managers, one thing we have very clearly observed, that the circulars that we sent from NACO are not disseminated to both medical officers or to nodal officers. Sometimes they are shown to one medical officer, sometimes to another, not to both, and nodal officers rarely get to see. The guidelines are very clearly there that this should be printed out, kept in a file, signed by nodal officer. Are we really fast tracking the patient with cough at ART centers? Are we really keeping the masks at the center's entrance? So there are many things other than prescribing the drugs. We have recently sent out to our regional coordinators to get data 100 patients from each ART center to see what are the immunological failure. This can very well be done by ART center themselves. As against a target of getting 50,000 patients on ART, at the current failure rate, we are getting only 11-12,000 on second line ART. So all these patients which are supposed to having immunological failure, supposed to go to second line, are continuing on the failing regimen and accumulating mutations. It is somebody's moral responsibility. It may not be your legal, ethical, there may be no action against you for not doing this, but there is a clear moral responsibility that you do certain things which are minimal, and that is the quality. You need to see that all patients have CD4 regularly 6 months. It is viewed, it is entered, it is reviewed, and if it is declining, the action has to be taken as per guideline. So these are certain things that I wanted to share basically, and I would again like that you should work as a team, and every center should have a weekly meeting amongst themselves and a monthly meeting with the nodal officer or the ART team, and quarterly ART teams. Thanks a lot for your presence. And lastly, I would request all of you to be present in large numbers when anybody is taking a NDLS. These are learning opportunities, and all of us, even we learn when certain experts issues on the technical sessions, and everybody learns from that. Thank you very much.
Thank you so much, sir, for your guidance and support. I request participant to kindly vote on the e-poll. You can see on your left side of the screen. Kindly vote on the e-poll. The recorded link of this session will be forwarded to you. Thank you so much. Thank you all.